Hello and welcome to Best of the Day from the 2013 ASCO Gastrointestinal Cancer Symposium. This is the 10th anniversary year of ASCO GI, and it's been a very interesting meeting thus far. Today is day 3. This is Colorectal Day. So joining me this afternoon to review some of the data presented at the meeting this morning is Dr. John Marshall from Georgetown University Medical Center. John, thanks so much for being with us, and thanks for taking the time to enlighten us a little bit.
Well, thanks a lot. I mean, I didn't even realize, but I've got perfect attendance at this meeting. I've been to all 10. I got a little ribbon for it. I'm very proud.
I knew they had a whole list of people who had attended all 10. That was very impressive. Yeah. Of course, some people, weren't even in medicine when that
That's right.
started. Yeah.
Maybe I need to get a hobby.
2003 to 2013, it's been a very interesting decade, not just in gastrointestinal cancers.
Yeah.
So this morning there was a very interesting presentation by Charlie Fuchs from the Dana-Farber Cancer Institute looking at aspirin and NSAIDs. And there's been a lot of evidence, a lot of trials as to what role these pharmacologic agents play in prevention of colorectal cancers, especially people with hereditary polyposis and this sort of thing. But now it looks like there may actually be somewhat of a therapeutic role as far as adjuvant therapy for resected patients. Plus, he also went into potential biomarkers as selectivity criteria for the use of these. So tell us about aspirin and NSAIDs and how you see the state of that field at this time.
Yeah, it's really a fascinating story in my opinion. So I've long actually recommended to my colon cancer patients in the post-chemo or post-surgical setting to take a baby aspirin a day. There's been some really strong evidence that decreases the risk of formation of new polyps in that group, whether MSI high or not. But then there began to emerge some evidence that maybe something as simple as an aspirin might in fact prevent recurrences. And we didn't really understand how. We're still not sure we understand how that would work. But fortunately, Charlie and the group up in Boston has access to just some great databases of people. In this case, it was called the Physicians Group. It was published in the New England Journal, so real data, real important. And what they did is they took this group of folks that they've been following over the decades now, a high number of people, and said, well, who's taking aspirin and who's not? And who got colon cancer and who didn't? And who had colon cancer taking aspirin and didn't have it come back? Right. And when they sorted all of that out, they actually uncovered that there were a group of patients who, because of aspirin, didn't have their cancer come back. And they actually drilled down on this. The target that emerged out of this study is the PIK3CA kinase target, which turns out to be mutated in maybe as many as 20% of all colorectal cancers. The day this New England Journal article comes out, I got 3 emails from patients. Should I be having my tumor tested for this target? Right. And my answer today is no, because on the one hand, while that might suggest a group that's benefiting, if you didn't have the mutation, then should I not give you the aspirin? Because, of course, aspirin is very well tolerated, particularly baby aspirin, and it has other additional benefits such as stroke and heart attack protection. So, I think there's very strong evidence now that almost all patients in the adjuvant setting should be taking baby aspirin if they can tolerate it. And certainly this group that's emerged, maybe, just maybe, we should be thinking about NSAIDs and other kinds of therapies in even the metastatic setting, but clearly in the prevention setting. Along those lines, it's perfectly aligned with the major randomized clinical trial that's going on around the world in the adjuvant setting, which looks at, everybody gets Folfox or Zelox, depending on where you live in the world. One question is 6 months versus 3 months. But what we're talking about here is there's a second randomization to 3 years of celecoxib versus placebo. And when this trial first came out, I was a little, this is kind of crazy. But is something like celecoxib going to become our tamoxifen, where you take it for long term to prevent recurrences? So that 3-year maintenance or therapeutic impact of an NSAID, in this case high potent COX-2, on outcome for patients is just going to be very cool. We have to watch for it.
Well, I was impressed by, in the retrospective studies, the hazard ratios for those who didn't take aspirin versus those who did take aspirin. Those were pretty impressive.
Yeah, much more impressive than our chemotherapy hazard ratios.
I would look back at the Mosaic trial, and the hazard ratio wasn't nearly as good.
A blink of an eye, right?
So you wonder, in the elderly patients where oxaliplatin-based regimens don't seem to make that great a difference, how important is going to be the role of aspirin or celecoxib? And the other thing that I was impressed with is it's sort of reminiscent of the tamoxifen data in breast cancer. Tamoxifen presents hormone receptor positive breast cancer, maybe not triple negatives or non-hormoners. And aspirin and NSAIDs may prevent the COX-2 expressing colon cancers, but not the non-expressing ones. So I think this trial, 80702, is that? Yeah. I think the results of that are going to be extremely interesting.
And important for our patients on both sides.
Absolutely.
Less chemotherapy,
Absolutely,
I hope.
and just a reason why people definitely should go on this. Number one, to find out how much chemotherapy is really necessary. And number two is whether or not these NSAIDs make a difference.
Yeah, accrual's been good, high, patient acceptance high. I'm always interested in the study because I would have predicted that people would want to be on the 3-month arm. It turns out, at least in Washington, they're nervous on the 3-month arm. They want more chemotherapy.
Right.
So nonetheless, it is accruing well, patients accept it well. But the other piece is, you know, it's funny when we bring a new medicine to the table, we often think that the molecular biologists in the labs are really the ones teaching us about pathways. But really it's our patients, right? We give them the medicine, whether it's an EGFR drug teaching us about KRAS or aspirin teaching us about PIK3A, right? So these, you know, these drugs, if you will, are teaching us about the drivers, or teaching us about the subtypes in the clinic.
Right. So let's move on. I mean, this is really interesting, and will be exciting to see the results. But Peter Campbell from the American Cancer Society gave a very interesting discussion of the roles of body mass index and obesity and exercise in prevention and also in recurrence. So I have an extremely important question to ask you. This could impact the lifestyle of millions of Americans. Are you ready?
Absolutely.
Okay.
Yeah.
Is it better to be an offensive tackle with the Washington Redskins and have a BMI of 40, or a scrawny nerd with a BMI of 19 who spends their entire day on their Xbox?
Yeah, I think I'd be the skin. You know, yeah. So it's really, this is really important emerging data. We have been fixated on our chemotherapy and the impact there. Well, this data, it's both in breast cancer and in colon cancers, increasingly strong that body style or lifestyle, exercise, body habitus does translate into an outcome benefit, and a large one too. You talk about risk reduction, it's also very large there. So nowadays, for example, I have a stage 2 colon cancer patient where I'm talking about a 3% benefit from chemotherapy. Maybe instead of a little capecitabine, I should be prescribing Nikes and go out there and you know, you always say, you know, when you're our age, you say, I'm going to get in shape one of these days. There's nothing more focusing than a cancer diagnosis. And the reality is the impact is high. So if we stress this in the clinic to our patients, a little like stopping smoking, if we stress now's the time to do it, there's a pretty high compliance. And it's not just, you know, going to the gym once a week. At least the colon cancer data, it's about 45 minutes a day's worth of walking, okay? So I will jokingly prescribe a dog to patients. So go out there and walk the dog. But the more, breast cancer gets off easy again, a little less exercise has been proven to be a benefit. But physical activity, we don't know the mechanism. I think it might be through the insulin growth factor pathway. but clearly shows a reduction in recurrence. So now pop a little aspirin, get some Nikes on, park your car far away, take the steps at work, walk your dog, go to the gym. All of those things are important. And you are in control then of your own risk in some way by doing these things. And patients have been very high on this.
Right, and they talked about at least 150 minutes a week of exercise or 8 MET hours and this sort of thing. So whether it's a treadmill or whatever. And I think the other really important thing is you need to get started on this before all that excess baggage destroys your hips and your knees and your ankles, and then you have difficulty doing it. So that's really important, and I guess it's just going to take time until we know, which is the major factor, or is it all three? Is it the body mass index? Is it the exercise? Is it the insulin growth factor receptor pathway? I guess we'll just have to wait.
Well, they
see.
did look at the exercise question irrespective of weight. And so you can be heavy. That's why I wanted to be the lineman. You can be heavy as long as you're physically active, and it seems to have a protective effect.
There's been more data about that recently, about even people who are heavy who are physically active do better. So those Redskins, they'll be around for a while.
Well, I don't know. Not the Redskins. They throw them out on the field with broken legs.
Right, and, what are you going to do? Okay, well, let's move on and talk a little bit about screening. There's a very nice presentation today that I think still left me a little up in the air as far as the guaiac fecal occult blood test, this fecal immunohistochemical test, or the FIT test, versus flexible sigmoidoscopy versus colonoscopy. And there were comments that colonoscopy may not be as good for right-sided lesions as we might have thought it was, that there's a lot of things missed on the right side because the lesions are not usually pedunculated. They're more sessile or serrated. What is your take on all this? And when you see a patient that says, what should I tell my friends and my relatives about what they should do to avoid the condition I'm in?
Yeah, so first our patients, we generally have them get colonoscopies, and that's sort of their thing. But the average person, the cocktail party conversation person, what's the recommendation? It first starts to me of just do something. This is part of the uphill battle we've had with screening in this disease. We have a very high level of people who go out and get their mammograms and pap smears. Maybe more than they need, right? But in colon cancer, we've really failed to capture our audience. And there's a lot of reasons, of course, why. But then we held fast, at least in the United States, that colonoscopy was the gold standard, and we said nothing else really will do. Well, that's not, as you cited, not really what the data says, is that yes, if you're going to go through the prep and you're going to do it all, well, might as well have somebody who's there who can snare it while they're there, and so it's one-stop shopping. But when you think about populations, and this is where I really am thinking, struggling with a bit. I want to tell you a little story. So I was in Ireland recently, just to give you a sense. There are 4.5 million people who live in Ireland. Believe it or not, there are only 30 oncologists in the country.
That's amazing.
Isn't that amazing? So I live in Washington, D.C., where there are about 5 million people, and there are more than 200 oncologists in Washington, D.C. To just give you a sense. So they are not one of the rich EU countries, but they've decided that they're going to do colon cancer screening. They've decided this is important for their population. And they're going to use FIT testing, just as an example. Well, they know roughly how many colon cancers they're going to find. They don't know under what rock, but they know roughly how many they're going to find. They know what their capacity is in hospitals and ORs and gastroenterology offices. And they recognized early on that they can't do this all on 1 year. They'll flood their system and it won't be possible. So they're consciously going to spread it out over 3 years. The reason this struck me is in 2014, 40 million Americans will have health insurance that currently don't. Okay? They'll either pay a fine or they'll have health insurance.
Right.
And we expect most of that health insurance, these exchanges and things, won't be premium policies. But I suspect a large percent of this 40 million is going to say, well, now that he forced me to have health insurance, well, I'm going to go use it. right?
Absolutely.
So they're going to go to their primary cares. Well, do we have enough primary cares? Primary cares are going to say you're going to need a colonoscopy. Do we have enough gastroenterologists with capacity? But we haven't really assessed what this spike in 40 million people is going to do to our consumption, all the way to finding hypertension, cardiovascular disease, cancers, and the like. So we're going to find a lot of stuff under those rocks as we go forward. So what should be our policy around colon cancer screening? And I, like you, am something is better than nothing. Right. And so if we can get this patient population to at least do some stool testing, these are valuable tests and they're improving over time. There was a poster today about blood tests that are looking more and more promising. But I'll take any of them. I mean, we can quibble about what's the right way to go. But I'll take almost any of them. For me, still, give me a good gastroenterologist, a good clean bowel prep, and I want a colonoscopy. Now, you know, I can get all those things readily, and it's not too much of a hassle for me. But for those patients who can't take a day off work, you know, to do the prep and have their anesthesia, or who are just freaked out by the whole process, make sure they at least check the box of one of these stool tests, because there's clear evidence they reduce mortality.
Well, there was a very interesting comment during the discussion today about the time interval between your prep and examination. And they said some people are now splitting the prep so that they get a much cleaner colon. And they said, you know, if you're going to get a colonoscopy, it may be good to be the very first one on the docket in the morning as opposed to the one at 3 o'clock in the afternoon when your gastroenterologist is tired and fatigued and maybe the effects of your prep are wearing off.
Yeah, no, I think that's all true. But at my place, I get to be the first out, right?
Good for you.
I'm in charge there. So, but I think that's good advice for everybody, yeah.
Absolutely, absolutely. So do something.
Do something.
Do something.
And this does fall to our primary care docs who just have a hard life. And you know, they've got a lot of boxes to check themselves. EMRs, interestingly, electronic medical records, have helped in this regard. They have, you know, if your primary care EMR, they, you know, notices you're 50, this pop-up keeps bugging you and says, have you, you know, recommended a colonoscopy yet? So those kind of triggers that are being built into our electronic systems, I think are going to pay out. I think on the other end, I bet we see more and more involvement of the payer in this, that the expectation that if you've done your cancer screening will drop your rates.
That would be nice.
It would be nice.
That would be nice. All right, well, let's move on and talk about some of the more basic science of colorectal cancer. There were some interesting presentations late this morning. One looking at BRAF mutations, why colon cancer patients with BRAF mutations aren't as sensitive to BRAF inhibitors as, say, melanoma patients with the V600E BRAF mutation. The status of immunotherapy, especially with the checkpoint inhibitors like ipilimumab and the anti-PD-1 and PD-L1 antibodies, and then also what the role of MET is. We hear so much about MET amplification and MET overexpression in a lot of other solid tumors, renal cell and non-small cell lung cancer, and even in some of the upper GI malignancies. So let's talk about BRAF. What is the status of this gene? How important is mutation? And what can we do about it?
So we can't catch a break in colorectal cancer, you know. We have these mutations. We have drugs against these mutations. Over there in the lung cancer meeting, you know, they trip over crizotinib, you know, and all of a sudden here's 7-9%, whatever the percent, with a drug that works really well, right? The breast cancer people, you know, I have breast cancer envy. You know, here's a HER2 targeting drug, and instead of little bitty curves, you know, separation, whew, big deltas that they see when they find the right drug for the right patient. But even when you look at our KRAS story, so we think that's pretty good, right? But even then, the curves are not very far apart. We're not having these big impact, carving the disease up, if you will, into its subtypes. And as I think about this, one, colorectal cancer has a lot of mutations, 50 to 75 in a typical colon cancer. And it's a little bit like measuring the traffic. To measure one gene in one patient with 70 broken genes is a little bit like here in San Francisco taking one street corner and taking the traffic picture and saying, well, it's okay there, and then saying, okay, I can get to the airport in 10 minutes, right? So, because you don't know what's going on out there, right? So we need to, in colorectal cancer, I think, develop some new rules about how we're going to use targeted drugs. We need to develop this kind of phenotype that goes along with the genotype. So it's not going to be just one gene. So BRAF, the story as you laid out, BRAF mutations, you'd think the BRAF melanoma drug would work well. Well, it didn't really.
And it's the same mutation.
It's the same friggin' mutation. And so why wouldn't that help? Well, clearly there are other pathways. In that melanoma, it's a critical driver. It's like a c-KIT level of a driver in that patient. Whereas in colon cancer, it's just one street, and if you want to, you can go around the corner and get to the same place.
A lot of bypasses.
Yeah, absolutely. So we need to understand the traffic in colorectal cancer, not just single mutations. And as we've talked about, there are emerging, some smart people are looking at gene profiling, if you will, to try and sort colon cancer into some bigger buckets. Sabine Teshbar back at ASCO of last year, and then new publications here this year from the Coloprint gang with Josep Tabernero giving the presentation. They're starting to say, well, okay, we can do it in type 1, 2, and 3, or Sabine's work is 5 different types that are taking into account not only the histopathology, but then these bigger subtypes genetically. And I think once we start doing that, then we'll find some common threads in there. You know, we've always bunched young people colon cancer and old people colon cancer. Right side, left side. We've said it's the same disease.
Yeah, we know
and
that.
It's very
not
clear
true.
It's not true. It's very clear. And we haven't been able to figure out how to sort them out. So I'm actually excited and encouraged about what's coming. Both the frustration and lack of benefit, but also the understanding of gene profiling is pushing us to understand the biology of this disease better before going forward. In fact, at some of our side meetings, we've been talking about, no more big phase 3 randomized trials until we know what the heck we're doing.
Yes. Smaller
Studies, enriched studies. Not just giving everybody the same treatment and crossing your fingers that you'll get a 1.4 month improvement. And so these negative studies are teaching us, our new biology is teaching us. Disappointing about BRAF, don't throw them out. We're going to figure out how to use these drugs, but it'll clearly be in combination.
Very good. What about immunotherapy? Yeah. Probably the most exciting topic at ASCO in 2012, the checkpoint inhibitors, the anti-PD-1 and then the anti-PD-L1 antibodies. There were some colorectal patients in these phase 1-2 trials, but the impact did not seem as significant as what was seen in melanoma and renal cell and non-small cell lung cancer, which was a real surprise. Yeah. What is the difference? Yeah. Or do we know?
Yeah, Howard Kaufman gave a nice review today from Rush, and actually I'm on the program committee, so I wanted this topic. This was my topic because I've been a long believer that the immune system is really going to be an important answer for us. And as the last couple of decades have been the decades of targeted therapy, my hope is with these new checkpoint inhibitors that we're going to now enter into a decade of immunotherapy. If you go back, those of us who are old enough to remember, there's plenty of studies out there that colon cancer is an immune cancer. Not quite renal and melanoma in that regard, but it is an immune cancer. There was a Dutch study where they gave patients their tumors back and had an immune response and an improved outcome in survival. We know from primary tumor analysis that if we look at the regulatory T cell populations within the colon cancer, it's a much more potent predictor of outcome than anything else, and yet we kind of ignore it. It's not on anybody's path report, right? And we've known that for the last decade, we and others have shown that if you can get a patient's immune system to recognize tumor antigens and mount T cell responses. What we failed to do is maintain those responses or get them high enough, if you will, to fight off a cancer without significant autoimmunity. These checkpoint inhibitors will give us that. So I don't think checkpoint inhibitors by themselves are going to make colon cancer better. Checkpoint inhibitors are a little bit like IL-2 in some ways. So IL-2 is dialing it up, while checkpoint inhibitors are cutting the brakes. So in an immunogenic cancer like melanoma and kidney cancers, you're going to see primary responses from just that immune therapy. In the solid tumors, what we're going to need is combining. We're going to need probably a little chemo. We're going to need probably some vaccine to turn on the immune system against the antigen to sort of start the fuse, because that's how the immune system works. So if you can get the T cell against a CEA peptide, for example, and then you kill that cancer cell and you cut the brakes, right? That's the idea. Well, that immune system will not only see that CEA, but after that cell dies, it'll find that RAS mutation, it'll find that P53 mutation and recognize that as foreign, and there'll be spreading of the recognition, and the immune system will learn.
So the chemotherapy will help hopefully kill enough cells, release a lot of antigens, and hopefully there will be recognition, and then you get those CD8 cells really going at it.
But even if you look at, let me give you the example of approved immunotherapy in solid tumor. Let's go to Provenge, okay? So Provenge doesn't do anything for PFS, right? So it's control
strictly
versus
survival.
vaccine. It's only when they gave Taxotere after. So you primed the immune system, and then you had to kill some cancer cells. And that's when those curves separate. And that's been true time and again. So I think the role of immune therapy is going to be in the adjuvant setting, for long-term memory if you need to give some chemo, but low tumor burden in the adjuvant setting, or coupled with chemotherapy to see if you can start this fire.
Very good. All right, finally, CMET. What is the role in colon cancer?
So we have to kind of back up on the story. I don't know completely what the role is going to be, but what we do recognize, again from negative adjuvant studies, is that micrometastatic disease may be different than established metastatic disease biologically. And this sort of mesenchymal epithelial transition that we think happens. So envision it that the cell that gets sown is actually morphed in a way that has different gene expression. Okay? Then it lands in the liver or lungs, and it sits there for a while in that somewhat dormant state, but different genetically. And then, I don't know, angiogenesis or something happens, and it morphs back to that vanilla adenocarcinoma. Right?
Cell, yeah.
So what we think's going on, at least in colon cancer, is that maybe that's what we're treating in the adjuvant setting, that morphed different cell. And one of the characteristics of it is this high MET expression. And so I was looking at that paper today, and I was thinking about, the MET role in hepatocellular cancers and the like, and I'm sure there's some link there about microenvironment, liver-only disease, this kind of thing that we'll learn. But knowing this, if we can understand that micrometastatic cell better, that's our best way forward in adjuvant therapy. Instead of taking a bunch of drugs that work in metastatic disease and apply them in the adjuvant setting, at least for colon cancer, that hasn't worked, right? Just 5-FU and oxaliplatin are the only ones that played. We need to understand that cell better, because I think that's what we're hunting in the adjuvant setting.
The science has gotten really interesting, but we're not quite there yet with a lot of these things. But it's progress, and it's very hopeful for the future.
Yeah. No, it's been a great 10 years, as Rich pointed out today at the meeting. And if you think about where we were 10 years ago, it was before all these new drugs really started to take hold. We didn't understand the concept of, biomarkers and targets and all of that. So we've really evolved a lot. The key going forward, in my opinion, is going to be shared data. I think, all those docs out there grumbling about entering their data in electronic medical record. We have to build the haystack so we can find the needles. The concept of big phase 3 randomized trials is probably falling quickly by the wayside. More I-SPY2-like studies, the lung battle study. This is where we're going. So you're going to do more biopsies, fewer CAT scans, and picking medicines based on an individual's tumor.
Enrichment of the trial population by biomarker identification.
And if we do that successfully, then the size of your trial all of a sudden is smaller, right? I don't need 900 patients to answer a study where there's a big delta. I can do it with 200. And wouldn't you much rather yourself be on a study that has a high probability of benefit. We just this year had new legislation for drugs with significant benefit have a very rapid approval process versus the more traditional safety and efficacy targets. So I think we're going to see more companies, more investigators designing trials with big deltas so that they get drugs, even though if it's 7% of lung cancer, that's a bunch of lung cancer.
That's a huge number.
And if you can do that much more quickly, then their costs of development go down. I see it as really the only way forward.
Very good. John, thank you so much.
Thanks.
It's always great to get together with you. You have a very entertaining way of presenting the data, and we definitely appreciate it.
Glad to be here. Thanks for having me.
Oh, you bet. And thanks to all of you for watching this segment of Best of the Day from the 2013 ASCO Gastrointestinal Cancer Seminars. There will be more later today on colorectal cancers with Dr. Axel Grothe, so be sure to check back with us. Thanks again.